Thank you so much. And this is a very important group because this is a project that to be able to push it forward to stimulate all the ones that are do a follow-up in the region. And the idea is that they can share this information so that we can generate the information that we need for the things that we've been talking about, which is the generation of public policies that our kids need, and also based on successful experience within the region. And okay, I want to tell you that this group is going to have the following dynamics. Dr. Sergio Consolino, that you already know, and it's the person that is going to show us the agility, and it's going to tell us how do we feel the information. And on the second place, we're going to have Dr. Victoria Rizzo, who is going to reflect on what should be and what should be on and what a database should deliver, what it's the knowledge demand. And so on the third place, we're going to talk about the first report, that it's very modest, but it's still the first report and the first effort. Sergio. And thank you so much for the invitation. I come from Rosario, from where Messi comes from, so that you know. And we in the year 2023, when we got together in ALSEPNEO, and therefore, we can see that you have the possibilities of having the database and to be able to work with those patients that we see at the office. The idea is to contact those that do a follow-up, and therefore in 2027 we can have higher data. We are going to see what do we do at the hospital. I am a physician, and I also do in the office. So one was in contact when the patient was in intermediate care and when the patient is about to be discharged. Prior to discharge, what we do is that we start loading data, and we are going to interact with the family in hours. So we are. And therefore, we are going to have a follow-up nurse that it's like a traffic light, and it's a bridge between the family and the consultant. We have an electronic record. Now I'm going to show you how we can print the report either for the clinical records of the hospital or for the families. And of course, I have a family that it's delivered to the family so that whoever interacts with this patient, either if it's a multidiscipline, they can be able to do all the control tests of that patient. I'm going to show you a patient, and I'm also I'm going to show you an example with a patient. This is Elena, and I want to know the summary. Let's go to the patient's data. And you can see that I have the document number, I have the personal data, the birth, the weight and height when birth. Currently, the patient, it's a year and 11 months and 19 days. And in yellow, we can see how everything is corrected. Here we can see how the age is corrected. You don't need to do calculations because this is great. And therefore, Elena, I go to the diagnosis, and therefore I can see the diagnosis, and we have different we have elements, we have all the cardiovascular elements, and therefore if it was a patient that required respiratory support, we can see the days that the patient was in CPAP, how many days did the patient require oxygen. We can classify the patient had a pulmonary dysplasia, if the patient had a ductus, if that ductus was corrected surgically or if it was corrected pharmacologically. And when we talk about food, and therefore we can see what was the lower weight of the patient, which day did the patient had the lower weights, and we are able to determine how many days of parenteral nutrition did the patient has, if there was an allergy to milk protein, if the patient is breastfeeding, if the patient is taking hydrolyzed milk, if she had a mixed formula. And therefore, once we see and we start loading the information, we start creating the different diagnoses. And we can see Elena had an myelina, she had an allergy to cow milk, they had a retinopathy grade 1, apnea, she had sepsis, and therefore we can see there is an infectious part, and there is an area when I want to determine if I have postnatal infection, if I had a late postnatal infection, if there was an intrahospitalizary sepsis, if we were able to identify the germs, what types of antibiotics, how many days of antibiotics. If I want to do the prenatal history, and I don't remember if Elena had a C-section, there's an area that allows me to see. Here I can see the birth data, 31 weeks, 1 kilo, 190. I can see the weight, 136 as a cephalic per meter. What was the Apgar scale if the patient was administered corticoids, if it was a delivery, if it was a C-section, and when the patient was discharged, the date of discharge, and also the data was, did she have 39 weeks? Did she weighed 2 kilos, 225, 42.5. Here you can see all the data. And now, and therefore, and I would like to ask the patient, or then I see like a strategy. I see a strategy in the database, and we can see that the patients are in red and then green. The green are the patients that come to the office constantly, and sometimes we control them, and we do follow-ups every 2 or 3 months. And when they are in red, it can be that it's a late follow-up, or maybe the patient didn't show up. When we close up the program, and then I'm going to show you in the control, there always has to be a return date for the patient. If you add the return date of the patient, you can't close the program. And in the case that this patient is not coming, one needs to talk to the nurse, and we check out the personal data, and we have a cell phone at the office that it's turned from 8 a.m. to 8 p.m. where patients send text messages, and also the nurses answers. And there is a responsible adult that we see in the system. And we can see the grapher of this family. If it's a family, what's the income, how many children they have, what type of education do they have. In this case, it's just a single mother. In the case that the patient has passed, we also included. And I go back to the summary, and I wanted to check the patient's controls. And the controls, and Elena came up on Elena I, but here we can see the follow-up, the weight cephalic per meter. I am going to edit something. I am going to and here we can say there is an area that, although we have the data, and although we can see if the patient is being fed, and therefore in this hospital we're trained in CAD/LAM, but here we have the possibility to do the ACQ3, and we can do a diagnosis if the patient is going to stimulation or rehab. And here we were able to include the Catalan for 21 months. And I go back, and these do the day that I'm going off to the office for we can see that for under 2 every 6 months we do the potentials, and every 3 months we do the emissions. It sounds pretty, but sometimes it's hard because sometimes the patient doesn't return to the office. They missed their appointment, and we need to reprogram it. And Elena has done the potentials and the emissions, and the ophthalmological test said, well, here they allows you to see when is it the control. The last time that we saw Elena, we were doing the Catalan, and we were able to see that she would look on the toys. She was short-sighted, and then she got her glasses in less than a month. We were able to get her to wear glasses, which is not easy. And respiratory ACEs, Elena had a pulmonary dysplasia that she was able to solve, but she also had a bronchiolitis despite having a pavilizumab, and she used take inhaled corticoids that also can be marked, and there's also a respiratory pathology that you can also organize. So regarding morbidity, we can also include, and we can see if the patient has been admitted. We can also include, we have the general observations to be able to see if we can also see what's the blood pressure of that day and what are the indications. I wanted to save, and as I had done a control for the patient, and then I can say, hey, how is it possible? Because sometimes it happened that in the health center the patient is checking out, and the patient says, hey, I don't like it because Elena not growing, the size is not growing, she's not increasing their weight, or maybe the patient doesn't have a 6-month corrected age. And therefore one comes and says, hey, yes, yeah, you can see mother, she's not a 6-month corrected age, therefore we cannot feed her, but she's growing well. So therefore I say, look how she's growing, and therefore we show the curves, and therefore and we can see how Elena is growing. And if the mother was very short, and there was a delay in growth, and here we can see the observations that one starts including when they're at the office back then, a detail that I think that it's very good to take into account. And if the mother tells me, hey doctor, can you print this information so that I can take it to the health center, or less, can we print it and we place it in the notebook follow-up so we don't have to write the whole time. That's why we can print it, the clinical summary for the parents. And there you have all the detailed information, and we can see the name of the patient, the chronological age, the corrected age, the curve of how the patient has been growing, all the observations. We can see normal emissions from 27.3, the ophthalmological controls, and for the glasses, the Kaplan for 18-21 months, and then we can see the next control, which is the 25.6. And I close this off. And if I wanted to have something printed, but a little bit more detailed, and something clinical that leaves me here, it's much more extensive, and where you can see the data of the people, we can see we can see the cephalic perimeter, the height, the weight, the corrected age, the curves, and all the follow-up diagnosis that we are going to observe. You can see that we go, so as again, we'll repeat, and we can print it, and we can place it in the summary of the clinical record. I close the program. Then I go to the general part. I go to the beginning. And to be able to have an access to here, we need to have an informed consent of the area where we're going, and we send it to ALSEPNEO, and they generally send us this consent, we sign it, and they give us a password. Okay then, thank you so much. Good morning. As Sergio explained, a database like the one of ALSEPNEO plays a critical role for the follow-up of high-risk boys and girls. And I am going to focus into very specific points. And we are going to say what does it mean to load data and what should the base giving us and what should information should we get. When we talk about the ALSEPNEO database, we think about figures as the weight of the baby and variables as, for example, a pulmonary a pulmonary bronchodysplasia and all the records that we register in each visit. And what I am going to reflect upon means on what we found about the data. We can see that every data behind has a story. There's a story behind each data. We start with the nurse, that it's the person that looks for the clinical records, that organizes the data, that that helps us and is part of the team. And then in this case, we have the doctor that decides what data to load, how they're going to review, and they organize that information, and they load it into the database. And we can say that the follow-up team, that it's essential, that it's committed, that takes time in the follow-up and so that one can be able to include this to the database and what we call the center and the origin of everything, which is the family. And that's why I would like to highlight that there is a protection and a care of the data that we load on the database, and at the same time there it's also a very active participation from the family during the loading, because the information through their experience and the possibility that we already have to load those data in the database, they participate in a very active manner in the development of my country, Argentina, and also of Latam. It's to say that they are also involved in the loading of the database. A little bit what I wanted to reflect upon, it's that the data that gets in ALSEPNEO, it's not digital data. It builds itself. It initiates at the office. It initiates with the patient, and also therefore we can do something. It's and we're going to do an active process. And that's why what we are going to do when the patient is discharged from the neonatal unit, we load all the data, and that leads us to 20, that takes 20 or 30 minutes. And then we go and there we load all those data during the follow-up. That it's a little bit what Sergio explained. And then we print the report. And we give the report to the parent, that it's different to the report that we included in the clinical. We can see that the hospital has a hybrid process where all the patients have the clinical history and papers, and all of them have everything. They have something comprehensive. And that's why when we have this paper clinical record, the patient has this. And in certain way, we can say we included adding up ALSEPNEO, and we can see that all that story is based on the database. And then we add those data that we load in the ALSEPNEO database and are integrated in the integrated medical record, that it's mandatory. That is the process. That is what we committed to. This is where our follow-up team is. If we take that time, if we commit to perform, we want to see what is the value of doing it. What do we expect from the ALSEPNEO database? We expect data that we can use. We expect that this contributes to an harmonic development of the whole region. We do expect that there is a comparison of my center with other centers, and we also expect an evolution of our patients, and above all, we have an information that helps in the decision-making process. And that's why an example, it's a premature neonate 26 that we see during follow-up at 6 months, that has bronchopulmonary dysplasia diagnosis with a good growth. And okay, we have the data, we have the evolution of that patient, and what we want for the database to tell us, it's this. Can we expect this? Am I okay regarding other centers? Can I be better? This is where the database. It's important for us. And what do we need from ALSEPNEO? What do we need from this database? We need a context. We need to be able to share and transform data. We need accessible information, because if the information it's not easy, it's not usable. We need clear reports. We need feedback. We need to know if the data is well loaded. We need to see if there is something incomplete. We need to know how we can improve. And therefore, above all, what we need, what the teams need, it's acknowledgement. And because without we can see that there's no base. There's no database, and that's why it's not just loading the data, but it's returning that data for us being able to make clinical decisions. And that's why one of the ideas that the data comes back if the care improves, and if it doesn't, it's just gonna be loading data for the team. And finally, I would like to conclude with 4 definitions that I think are very important for these reflections that they invited me to do. It's the data, it's not digital, but it's that it's built, that each data has a history, that loading data, it's something that helps us to improve on clinical decisions, and that the base, it's built in a team basis. Thank you so much, all. Thank you, Vicky. Thank you, Vicky, so much. Great. And the last part of this discussion is to show you what we've been able to achieve during this time, and what we can extract, what we can certainly can obtain. That's why we would like to tell you that we've been 5 years, but since the 2nd year of the creation of us as ALSEPNEO, we started to develop this project, because this project, it's part of the work that this association does, to be able to shine some light regarding what's happening with high-risk babies in the region, in order to be able to adopt the different interventions. Without information, this cannot be done. That's why we adapted a database to be able to cover all the kids after prior informed consent of the parents. And this is so important, because parents need to know that there is information on the evolution of their kids, and they need to authorize it. And the idea is that once we fill in the information, all sensitive data, and I'm talking about the ones that could be in a healthcare insurance, ID, full name, the name of the parents, all that information, it's encrypted for analysis, and it's encrypted in the database, in the server. And the server it's located in a private space that cannot be hacked. It's unhackable. And progressively, we kept on growing until we are here, and we have 707 patients that have been distributed in 10 follow-up centers, of which six have been admitted in the last 6 months. And that's why it's hard for us to be able to do a complete analysis, because we don't have enough data of the children. In the 4th centers with the highest level of participation, we do a much more detailed mobility analysis. for the first time, we're going to show the identity of the centers, because the idea is that when we do a benchmarking, we don't show the identity of the centers, but over here we have something that it's descriptive, and that it's stimulating for those that have invested time and effort in loading up the information, so that they can have a retribution, a compensation based on data. As you can see, there are some recent data, 18 cases, 10 cases, many cases. And this is something that it's part of our universe, but they were not part of the morbidity analysis. The ones that load the most are the oldest hospital, Hospital de Rosario, Hospital Roberto del Rio, and also the Antonio Maria Benitines that is from Venezuela. And we have the HSMI from Argentina, that it's in blue, that it's where Dr. Rizzo works. And Provincial de Rosario is where Dr. Sergio works. What do we have? How have we been working? How are we working in the space? Data has told you that we can do all kinds of studies, and we can do social studies. We can do ranking according to the social level or the educational level. But to be able to get to this, we need more participation, and we need more data numbers, because with this information, we don't obtain anything. That is why the kids that were loaded with the mid gestational age was 31.5, with more or less with a minimum of 24 weeks and a maximum of 41. There is no child loaded in this 4 centers or 10 centers with 33 weeks. And we can see that the weight was 1,600 grams, more or less 602. And we can see that they go from 570 grams to 4,500 grams, because the database not only includes premature babies, it also includes a percentage that it's not much of high surgical risk encephalopathy and other things.
Since there are not many patients, to be able to stratify them according to diagnosis will give us some information, not information at all. So we need more time to upload the information to be able to have detailed data. So we need to strengthen and the consistency of the data. And be very careful in sharing all the information so it could be representative of the group. To be able to share and publish follow-up data, it's required to have a higher coverage above 80% and hopefully above 85% of the population that is part of the registry. So this is much more consistent, like gestational age, weight, and comparing these two, it's less precise, even though to define a gestational age is not precise as well. So here we need to consider this aspect, but this represents 95% of the babies who are in the registry. Since there are much more precise weight, this is a very good registry in this sense, because it considers hard data in 95% of the cases of the babies. If we do that, if we make a group by weight, there are children that not even appear. Therefore, out of the 700, we drop down to 600. So here, we need to upload the information, complete information, as you can see. Little babies, 909 grams are 65. less than 10% of this database is composed by a baby of low and extreme weight. Among 1,000 and 1,500, we have the majority. From 2,000 above, another good percentage. A majority of the children are less than 2,000, 77%. And out of these, the vast majority are between 1,000 and 2,000. Above 2,000, and we drop down to 96 cases, which are part that really represent 15%. Above 2,500, which would be on-term babies that enter the database through different diagnoses as prematurity, are 55 children registered, and a group above 2,000, 2,500 have another pathology associated above much more than prematurity. That's why maybe it's another risk. If we do that by gestational age, you can see that among 24 and 25 weeks, we had 13 children. Among 26 and 28, 99, up till 31, 29, 31. The vast majority of less than 82 weeks are from this group. Among 32 and 36 weeks, 328 babies that will be late and moderate. Above 37, we have 39 children. We wanted also to know the distribution of the group. Here we have that 49% are boys and 51% are girls. Okay, the weight at discharge was in an average of 2 kilograms, 600 grams, minus 800 grams. This is not a low weight, but we must consider this is the total group because we weren't able to stratify differently. So, size, height at discharge, we have less coverage, even though we were able to get 85%. We need to be aware that the information has to be filled out completely. So babies are discharged with an average height of 46 centimeters plus minus 3, and cranial perimeter at discharge at 32.9 minus 2.4. So I think it's okay. But this all depends on gestational age at discharge. So it's wonderful to see that the infants, the older infants, are discharged between 32 and 36 weeks, and it would be 69%, almost 70%. But in the group of 39 to 41 weeks, they're discharged. It's around 35% discharge. So these are possibly the infants that are, even though they're older, had other associated pathologies, maybe surgical or encephalopathy or other problems. 41 to 44 weeks of corrected age, which is around the first month of life, we see that 29% is discharged at this age, and there is a very other important percentage that are discharged later on, older. 32 and 36 weeks are leaving on 41 and 44. So when we can do an analysis by diagnosis, we suppose that these children, these infants, had something else apart from prematurity. In 2 months, 45 to 48 of corrected age, they're discharged. The vast majority of those who were born into between 26 and 28 weeks. And this is very important to get to know this, because we don't have no reason to say that our infants, from 2-month infants, are not vaccinated, because at least 40% should have been vaccinated when discharged. And finally, the infants between 49 and 52, 100%, just one baby. Above 29 and 55%, 75% between 53 and 57 weeks. Very, very little. They spent a long time. The units we analyzed around 4 months. So again, if they were until 2 months, the first vaccination dose, and if they were until the 4 months, they should have the second vaccination. So let's accustom ourselves to seeing these data. What was the nutritional condition when they entered the follow-up period? Okay, so we can see that the infants for 24 and 25 weeks that we know that are around 75% at 4 months started with 4 kilograms plus 1.6. This based according to the World Health Organization is very aligned. Okay, the same as the size and cranial perimeter. Even though the second one had a difference between these figures, it's important to remember that one little babies, some infants that being little are of higher gestational age, they entered early on. So this data must be analyzed when we have much more patients based on the gestational age. So this is going to be our next report. We tried to do an analysis, small analysis, regarding morbidity in our network, and we were able to do that only in 4 out of 10 because they have much more than 20 patients. It's not liable to do a stratification with less than 20 patients. We hope that more had more than 30 patients. So in these 4 centers, we can see that dysplasia has a differs due to diagnosis. Maybe this is the case. Okay, the idea is to use classification with oxygen dependent at 36 weeks, but it's very possible that this hasn't been considered in Pineda Hospital. Even though Pineda Hospital, maybe they receive bigger children, so that stratification can be done while the more information you deliver. It varies, the incidence varies among 15 and 13% in Hospital Clínicos Roberto del Rio. They care for little babies that they are referred from maternity hospital San Jose, 24 to 5 weeks. And maybe when we can stratify in that way, we're going to be able to explain this discrepancy. So we would like to invite you to participate with us. Intracranial hemorrhage is 31%, a very important number, I must say, and 15%. I wanted to share the information of the other centers that were not really registered or added up. Since there are few patients, the incidence of the problem is completely distorted. So it's very important in order to participate with all the patients. Retinopathy, you can see a diversion about 31% to 4%. Diagnosis in certain units is difficult to have compared to others, as we've seen with telemedicine. We need, as a network, to strengthen that. In general, the global mobility in these 4 centers of ALSEPNEO network with more than 20 reported patients is that we have a DBP of 23%, intracranial hemorrhage, HIC, 7%, 18%, retinopathy, 7.8%, hypoacusia, 1.5%. I think this is expected. Okay, so in this QR code, you can review this report in detail if you want to do so, and to take this as a preliminary report and to show and to share what we can learn to how the units behave in the region. It's very important for us to invite you, and we're open to guide you and to support you whenever we can with information. So in order to have a network with a lot of centers and that is really representative of all Latin America. Thank you very much. We have a question from Chile that says, I would like to know about the database. How has been your experience using the medical chart? Just one document during the visit? Well, in my case, we're in the hybrid process. We have the database and also the medical charts in paper and also the database of ALSEPNEO. So what we do is upload everything in the ALSEPNEO network. I copy that information and then I put it in the database of my province. So I do that. I just copy from one to the other. And you upload it as a PDF? So the system allows you to do so. Okay. There are some medical charts that are interactive. That's why I ask you, because some of them do not receive PDF. When control is done in these types of database of the hospital, which is mandatory to fill out, there are two ways to make this compatible. One is in real time, in which more than one person will fill out a database and the other one will fill out the other. If you don't have two people available to do the follow-up at the same time, well, what we can do is fill out the information in a different way. There can be the treating doctor, or we can have maybe some trained staff, maybe the secretary or technician or whatever, or anybody who wants to participate in the follow-up team. There can be a nurse or the MD or the phonoaudiologist, any member of the team that have maybe some available time and that will be responsible of filling out the information. Every unit is different. That's why I give that range, because we need to organize ourselves depending on the resources, the digital and human resources. Thank you very much. This is a contribution to the scientific quality that ALSEPNEO may have. And as academic director of ALSEPNEO, we need to have much more contacts in our congresses. My question doesn't have to do with your talk. That was wonderful. But would you like to do a workshop in the next Congress about this? Of course, yes, we would love to do so. We need really to teach the people and to show the people that this is very important, so that we may have much more units, more data, so much more reports. This is going to be very important. And I also think that those who participate in the network have an obligation, responsibility to be able to invite other centers. We have a certain representation among Chile, Argentina, Venezuela, Paraguay, but we need to keep on growing, because there are many countries in the region, and also this needs to be representative of each of the countries. So this is the invitation for Mexico that we know that have a unified chart, but we can organize ourselves to share with previous informed consent, all the information of your patients when we talk about high-risk patients. This is the invitation also for Colombia. Now that we're in Colombia, we should upload all the information. Colombia works in the monitoring, as you've been seeing, with the Kangaroo Mother Care Program that has a very wonderful database. But it's a question of organizing. And maybe a lot of information, maybe, what can I say? It's overwhelming. So the most important thing, sometimes this can be overwhelming. So interoperability of the databases is complex, I know, from the legal point of view, from the design, and talking about the objectives of each of the databases. So the databases can differ among each other. So this is a little bit complex. So the most simple thing, since there are not so many children with these characteristics, is to organize in the local work that we do. Thank you very much, Dr. Monica, and all the team for this wonderful talk. I would like to let you know that from 15th of April 2026, in Colombia started the interoperability of the medical charts with the objective of trying to do a follow-up to the EPS, IPS, the system, healthcare system in Colombia, how they're managing the medical charts and the information that should be uploaded in each of the institution. So this will enable us to see what are the medications are not being delivered to the patients, what patients are not receiving their vaccination, what patients are not receiving the monoclonal antibody for the mothers, and furthermore do a surveillance of the quality of the healthcare systems. Because in some institutions that have kangaroo mother care programs are really medical doctors, general medical doctors. These are working as pediatricians or neonatologists. And so I think this is a very important step that we're doing here in Colombia. And I would like to invite all the kangaroos that we have here in Colombia. Let's manage, let's share information. I have this patient, this and that, to see what is the gestational age. They're arriving to the center. In October, with Dr. Lombo, many neonatologists that do kangaroo mother care, we did a joint work, a wonderful work, and each one sent a report of how we are doing the kangaroo program. And how the babies are advancing. And we need to continue working. I would like to congratulate Dr. Lombo, Dr. Natalie, and you as well, that with each contribution that you give us, we will continue to grow. Thank you very much. So, in the back, we have another opinion from the doctor. Meanwhile, if there is local interoperability in the country, yes, I know, but it has a different objective to this critical point of view in the sense of the benchmarking, in which if it can be done very well in one place, in one same region, it should be able to be replicated towards other units in the same region. If there are successful experiences, they can be replicated. If we need to train the teams to be able to replicate those programs, we can do that. So this is the pathway that ALSEPNEO wants to travel regarding the collection of data that doesn't have to do with the assessment, as you said, as how things are being done from the administrative point of view of using the resource that the children deserve. So this is another focus. How is it maybe the kangaroo database has another focus? Yes. You are much more ambitious than us, that started since 1994, analyzing the kangaroo data in one, two, three, or four centers that are excellence units. And I want to really improve the kangaroo mother care program. Okay, we did it 2 or 3 times already with the tools available, but it's very complicated. It seems complicated. Now it's easier, but with a specific goal, which is we believe if in a country it's important to have an observatory. If you take Colombia, Manchocó, Guajira, Bogota, all the cities, you have a huge range for the low birth preterm baby with a lot of inequality. And it's very difficult to do an observatory together with the healthcare authorities to be able to make the decisions based on the evidence of its own country. It's not bad. You forecast all Latin America. We are going to forecast Colombia with an observatory. It's a simple thing, but I do understand because every country has its own singularities. Yes, you're right. That's the idea. The point of view of ALSEPNEO is to understand where we have maybe where we have an opportunity to help that center to obtain maybe experience. There are countries that don't even have one follow-up office, but in Chile you have structure. Argentina also has a structure. These are different levels compared to Colombia. So I would like to say at the Ministry of Health level, you don't have data collected that enable you to have global visions at the maybe at the level of the country, mobility, mortality. The Ministry of Health has different goals compared to us, to this network. We have a similar network in this Chilean Society of Pediatrics. So we highlighted some problems and needs of the Chilean babies, and we talked that with authorities. But we didn't give all the information to authorities. I'm not sure what is your experience, Sergio. Well, what I wanted to say is we want to really invite the people who are part of the network. There is a WhatsApp group, and always we have doubts. And we get together and we discuss once a month to learn. And if there are any doubts, we try to solve them through the WhatsApp group. Now, the Ministry of Health in Santa Fe has a registry, but it doesn't have a high-risk registry. So we have statistics with birth, mortality, weight, low weight, prematurity, but not like this. Any other comments, questions? In the back? 1, 2 comments, 3 comments. We still have 5 minutes. Okay. Okay, raise your hand, please. Good morning. Thank you very much for the talk, and to all the panel members. Thank you very much. I'm from Peru. I belong to the follow-up of the Institute of the Institute in Peru. It's very important to have this database. Like other countries, we have some difficulties, but now we have started. That's the most important thing. We have started from a screening to be able to capture the new patients of this year and to be including the fulfillment of a basic package, that is the name, basic package, so that the patient that is discharged can really fulfill that basic package that will guarantee to to understand, to be able to define a risk profile of this patient. Before the 2 months, we have another system that's going to say what's happened, this patient is lacking this and that. So this is the beginning, and we want to continue improving. Wonderful to have these conferences to be able to strengthen these processes. Thank you very much. Having a local organizations like the one you have in Peru, it's easier that the people who are filling out the information really wants to share much information towards a Latin American network, because it responds to different things. One is one vision, which is the local vision, country vision, and the other is the different vision is of a complete region, harmonious vision. So there are different experiences to be replicated. Angela? Thank you very much, Doctor. I would like to say that you didn't mention Peru, because Peru has some difficulties, like many Peruvians. And as my colleague already said, there are a lot of needs and efforts to be able to do or to build units. So what I wanted to say, the best thing that we can do if we want to do follow-up units is to start to use this strategy and many more. So it's important to have a database, joint database from the beginning. And I hope that for next Congress, there are much more units. We have a lot of difficulties in my unit, but we need to overcome these difficulties. And I hope not only when we want to be more, not only two. I said I cannot believe with everything I work, we're only two, but we need to continue working. And we need to fill out the data that's going to help us and to improve. And so we're going to see among Peru what are the strategies that work. What is the strategy that will improve immunity, and what works for me, my unit, and for the Latin American region. So I would like to invite all the Peruvians to be able to work with these new units that are starting, like the child unit, and to fill out the data and how they're discharged, to be able to see what we're doing. Thank you very much. And okay, and the effort to ALSEPNEO, yes, work jointly with ALSEPNEO. I would like to invite you, because this is a database that is going to be enabled to improve the follow-up in Latin America with our standards. We need to have solidarity. We are building towards the region, and I do believe for the stronger region to be able to be as generous enough and to have this solidarity to share the successful experience. This is what really unites us in ALSEPNEO as a society. So I would like to invite you, please, for the next Congress in Guatemala, we must be more who will contribute to the database.
Solidarity with knowledge.